We'll do that.
There you go.
That changed the slide when I wasn't ready, but we can do that. So I'm going to talk about osteoporosis. And I'm not going to try to cover the entire field of osteoporosis in my 40 minutes or so assigned. I'm going to skip around a little bit, try to cover some highlights, and try to bring to your mind some questions, and then I'll take all your questions at the end. If you have a burning question in the middle, you're going to forget in the end, just raise your hand and I'll try to answer it and not distract from the entire presentation. But we don't have to go linearly. It's okay if we power out. So this is osteoporosis. Osteoporosis has a simple definition: a disease characterized by low bone mass and deterioration of bone structure that causes bone fragility and increased risk of fracture. This is a bone biopsy of a vertebra, okay? One of your spine bones. This is what it's supposed to look like. It has all these little cross pieces up and down, back and forth, with a bunch of little holes. And when the bone gets bad, the holes get bigger, the cross pieces get thinner, some of them break, and then you have big gaps where there aren't any pieces at all anymore. And it doesn't take too much to imagine that this bone is stronger than that bone over there. Osteoporosis is an extraordinarily common disease. I've noticed that we are, remarkably, for an osteoporosis talk, 50% men. So I'm not going to ignore you at all in this talk, I promise. Although most of the data is really for women. Men lag behind women in osteoporosis by 10 years. If you live 10 years longer than your spouse, you're going to get it too. It's just going to be 10 years later. So if you look at where we are now, 10 million Americans have osteoporosis. 80% are women, 20% are men. And 1.5 million fractures per year. So this is an extraordinarily common problem. Women after the age of 50 have a 50% chance of having a fragility fragile by the time you die. So half the women are going to have an osteoporotic fracture. That's how common we're talking about.
What kind of fracture?
A fragility fracture, a fracture you didn't earn. You know, you didn't get hit by a car, you didn't fall off a cliff or your roof, but you slipped down and broke something without any major trauma. So it's called a low impact fracture, okay? So what are the risk factors for an osteoporotic fracture? Well, age. Obviously, the older you are, the more likely you are to break something. Women more likely than men. Asian or Caucasian ethnicity are more likely to fracture. A previous fracture begets another fracture. If you've had one fracture, your risk of a second fracture is 4 to 5 times higher than if you've never had a fracture. This is a real issue in this institution. We did a little research study looking at all the patients who had an admission to GBMC in 2010 for a fracture that we thought was related to osteoporosis. Of these 110 patients, how many do you think were treated for osteoporosis when they went home? 3. 3 out of 110. The other 107 were ignored, or at least sent back out there without even a discharge diagnosis of osteoporosis, even though they had a broken hip, a broken spine, a broken something. It's not well followed up on. This is not just true here, but across the world. It's one of my jobs to try to get a different approach to this. Family history of fracture, particularly parental fracture of the hip. Small frame. If you're less than 128 pounds, your risk of fracture is much higher. Modifiable ones, a low body weight. You could gain weight if you drive. Low vitamin D, low estrogen, not enough exercise, too much alcohol, too much smoking, or taking steroids, which may or may not be modifiable. Those are the risk factors that we can affect to some degree. So this is the annual incidence again. Most of these are vertebral, but you can see we're talking about a huge number of fractures spread across your skeleton. If you've had a fracture, your one-year risk of a refracture is increased 26 times. Now, people worry about various diseases more than they worry about some others. Here's osteoporotic fracture. Here's heart attack. Here's breast cancer. It is 7 times more common than breast cancer. But we worry about breast cancer. And this is breast cancer month. Every NFL player is wearing pink this week. But we don't have anything for osteoporotic month. The players are not wearing something for osteoporosis. Yes?
How does it compare with prostate cancer?
Prostate cancer would be kind of in this level here. Okay?
About the same as heart attack.
Yes. Osteoporosis is not just pain. What happens to your risk of dying if you had an osteoporotic fracture? Hip and spine, a 6 to 8-fold increase in mortality. Now this is sort of a tricky question. Did you have a greater chance of dying because you broke your hip? Or were you so sick that you broke your hip and that's why you're really going to die? So it's a kind of chicken and egg question. And so I'm not sure that it's clear cut. But the best example is my mother-in-law. She's 93. She fell down in January of this year and broke her hip. She is never going home again. She cannot walk. She just can't. She can walk 4 steps, but that's about it. She has to live in a nursing home the rest of her life. She's been in the hospital 8 times this year since the broken hip. It's not for the broken hip, but for other reasons. But debility in general, it just progresses. So this is the kind of issue that we talk about. We'd like to prevent this if we possibly can. Now her problem was, of course, falling. You know, bad balance because she broke the other hip in the past and has a hip replacement on that side. So our problem, physician problem, patient problem, insufficient rate of diagnosis. In Baltimore, at least as of about 7 or 8 years ago, there was a bone density machine on every street corner. The DEXA salesman sold every primary care doctor, every gynecologist, everyone they could think of, a bill of goods saying, you buy a DEXA, you do 3 a month, you can pay for this machine. That was before they reduced the reimbursement by 50%, then 75%, and now most people have put them away, now use them as a coat rack or an exam table or something else, because they can't make a living doing DEXAs anymore. And so typically everyone in Baltimore has had a DEXA sometime. But maybe it was 10 years ago, never had a second one. So this is typical that they're not followed up very thoroughly. And I just told you what happens here. Patients come in with a broken bone, nobody follows up.
Question.
Yeah.
I've had a DEXA, but I've had a couple of these tests where you put your foot in something and they do something with the bone of your heel and say, okay, here's your estimated bone density. How worthwhile is that test?
Okay. As a population screening tool, the heel bone density is not bad. As a way to follow your bones, it's no good at all. So if you want to do, if you do a heel bone density and it's bad, then you need a real bone density done to see what it really is. If it's normal, it's probably okay. Now that kind of depends on you. If you've had arthritis in your feet, it may not be accurate. So I don't use them. I don't advocate it. We get paid so little for the whole thing that I'm not sure there's a good point in it, but they were popular in the past. They're not so popular anymore. So yes, maybe, but it's not a perfect tool. Again, this low physician awareness, particularly among orthopedists, in terms of following up. Now, that's not true across the board. Orthopedic associates who live over on Bologna Avenue, who have, 50 orthopedists, something like that, they have a full-time nurse practitioner who just does osteoporosis. So they're not all in that category of ignoring it, but some of them clearly are. And the issue, of course, is, do you want to take the drug? How long do you want to take the drug? Does it have side effects? All these issues which come up, which I know you're going to ask me about as we go along. Now, this is the same information I said that applies to other people. This is how well you all take osteoporosis medications when prescribed. So here we are, compliance over 2 years, probability of fracture. If you don't take 75% of your drug, it's no benefit. So if you are not compliant, not adherent to the regimen, it's a waste of time. It doesn't accomplish anything. So we know that adherence is critical to make the drug work, and we know that in other studies, 50% of patients in 1 year have stopped the drug for some reason. Cost, inconvenience, forgot, whatever the reason might be. So how are we going to reduce the risk of fracture? We have lots of things that we can do, and so we have to talk about these things that are simple to do and then get down